I was going through your rehab, and as I was looking at it, there were so many instances where, whenever you look on True Coach, you just have like the calendar view,
Hmm.
and you see the program, and you see whatever the last feedback was. And I'm going through and looking at the progression. It's like, yeah, that made sense. That made sense. But I got to some places, I'm like, what the fuck was I thinking whenever I did that?
All right, we're back here today with my coach, Will Morris, doctor of physical therapy, starting strength coach. And check out the link above if you haven't seen the first video in this series. So for context, Will, let's break down what's happened so far. Late last year, I had a neck injury. I got neck cranked in jiu-jitsu. I had a C4, C5 disc issue that was impinging the nerve in my neck and then was affecting the function down my left arm. And if that is not addressed, that can be a real problem. I've seen many fighters that have had a similar injury and their arm is just totally atrophied. So I am very lucky. I'm very lucky because I know Mark Ripito and I'm aware of starting strength. And that's the thing that made me aware of this problem in the first place. And I'm very lucky because based on me knowing Rip and starting strength, I also know Will. And Will is one of very few people in the world that has the skill set that he has. I don't know where I would have gone for help. And this was theoretical at the time. I was confident in Will's capability. But here we are 7-ish months later, and the recovery's been phenomenal. And I know if I programmed myself, I definitely wouldn't have got it right. Because, Will, you did some stuff. You drove my deadlift up to 420 within, I don't know, 4 or 5 months, but you held my squat back. And you're doing some things that are outside of my level of experience. And my number one goal throughout this process was I don't want to get hurt again. I don't ever want to have my neck opened up again. So goal number one, let this damn thing heal properly. It needs to fuse. That apparently takes about a year. Goal number two, get function back. So it was the barbell that revealed to me that my arm was not functional because I couldn't overhead press the bar hardly when I discovered I had an injury. And then it was the barbell that helped me get back to normal function and get some symmetry in terms of my strength between both arms. And, I don't have any major atrophy or any major issues. And dude, so actually, let's just start there. Thank you. Fuck, man. I really, really enjoy doing physical things. And I came home from the hospital in a neck brace with the drugs wearing off and, in excruciating pain, and I'm lying there, and I feel like I'm a patient, right? And in those moments, I'm sharing this because for those of you that are going through something similar, it's important for context just to realize that all stuff heals as long as you take the right approach and you're in the right condition. But man, that was tough. It was tough, and it was extraordinarily difficult for me to be in that neck brace for 2 weeks. I think it was 2 weeks. And then it was extraordinarily difficult to not do any physical activity. I had to change my diet because at 250-ish, my weight was staying around the same, but I was getting weaker and getting softer. Had no physical outlet. This was a physical issue that became a serious psychological challenge to overcome. And I am very grateful to you, Will, because I believe that I would not have the functionality that I have now had it not been for your guidance. And the reason why I think this is important for our audience to hear is, number one, there are options out there that may not be standard conventional options. And number two, I want to reinforce the point that your healthcare is your responsibility. It's a point that Ripito makes a lot, and it's very important. The reason I say that is because, especially in this country, our healthcare system is so segmented and so specialized that there's no one that's going to have the ability to look over your entire situation. My surgeon admittedly doesn't know anything about rehab, which is understandable. So she just refers me to PT. And Will, no offense, but I think Rip's right about PT. I think it's mostly bullshit, unless you use the stress recovery adaptation process. The second point about my surgeon is that I told her I was on testosterone replacement therapy when I got the surgery, and she's such a specialist and she's phenomenal at what she does. She advised me to be careful with steroids because it might inhibit bone growth. And I was like, shit, that you're thinking about catabolic steroids, which is a shame because there are FDA approved drugs that are out there that are made for, cancer patients and women with osteoporosis that can help the increased bone density that actually would probably be useful for people post-op. But my doctor doesn't know about this stuff. So I have to know that the knowledge is up to me to procure. And then just lastly, I want to share with you guys to give you another example number 50 throughout my life of why you really have to be careful with trusting medical professionals without managing the situation yourself in terms of your health. And that is, my mom called me crying 2 weeks ago, and she had just got off the phone, or I think she'd visited her doctor. And according to her, her doctor told her she is a walking heart attack. She's a heart attack waiting to happen. So I was like, well, let's figure this out. And Will, bear with me. I just want to share this quick story because it totally relates to what we're doing. She breaks it down for me, and she's 67, and her doctor indicated to her that based on her calcium score, she's in the 99th percentile of women her age, and that's a major problem. And for the fourth or fifth time, they pushed a statin on her. And I advised her in the past to not take a statin. They were pushing it so hard that my mom actually wanted me to talk to her doctor. I don't know anything about this stuff. I'm not a medical professional. I've read a book about cholesterol by Dr. Malcolm Kendrick. Rip has taught me some stuff. I've done some research online. However, the research I have done indicates that there is no evidence that shows that taking a statin for a woman will reduce your risk of heart attack. There's no evidence that I could find. And I raised that to the cardiologist, a cardiologist of 30 years, who, by the way, earlier in the conversation mentioned to me, this is the standard protocol for all people in his profession in this country. And I said, well, is it possible that you guys might be wrong? Because he also said, I run an evidence-based practice, which is a phrase that doctors throw around. I don't think they know what that means, because I was talking to him about an anecdote about someone I know, my father actually, that took a statin and had a nasty reaction. And he said, yeah, that's anecdotal. We're an evidence-based practice. I said, okay, then we're on the same page. If you're an evidence-based practice, please email me a link to the peer-reviewed study that indicates that a statin will help increase my mother's chances of living a high-quality life and extend her life and prevent her from having heart issues. And you can point to some stuff that the statin can benefit you with, like it's got some anticoagulant properties, because there's no correlation between dose and lowering of LDL. And then there's some really weak correlations between LDL and risk of cardiovascular disease. So it's assumption upon assumption upon assumption. Am I right? I don't know. But is he right? He doesn't know either. So why are we taking risks like that? And this fires me up because it's my mom. And this is just the standard protocol. So thanks for bearing with me, Will. That's a very long way of saying, for you guys that know this and you want to take your situation into your own hands and you want to get more information, there are not many people. I've actually never met anyone that has a better understanding of the human body and how to repair it from injury than Will Morris. So Will's back with us today. And I want Will basically to break down exactly how he approached my rehab so that you can benefit from it if you ever find yourself in a similar situation. So Will, let's start there, man. Give us the context, the background, how you approached this, and what your overall, how you thought about this, and what you did specifically when it came to putting me back on track without putting me at too much risk of re-injury.
Yeah. So the first thing I'd say is, if you think I understand the human body and how to repair, rehab injuries better than anybody else, I would just say that you have a small population pool to pull from.
I need to know more people.
There's probably people out there that know this a whole lot better than me. But
I think you're humble, man. Nick Delgadillo rates you. When I asked Ripito about the nature of this surgery, he told me to call you. So there might be better guys out there. And if you're holding back, introduce me.
Yeah. Yeah. So I think one of the important things with your condition was that I think we talked about this on the last podcast, and I think it's important for everybody to know this, that this was not just, you tweaked your neck and you had some numbness and tingling down in your arm. That this was actually like motor function was being impaired, right? And it was being impaired significantly. You had overt weakness. And that right there is what was the impetus for us to tell you, hey, you need to go consult a neurosurgeon, which, by the way, whenever you went to your first provider, they were going to refer you to PT. They were going to refer you to me. And
this fucker said he'd never seen what I've had before. And he refused to introduce me to a neuro. And I told him, I have seen this before. And my understanding is that it's a neuro issue. And he disagreed and still sent me to an osteo. And he's the gatekeeper to my health, right?
Yeah. So whenever somebody has overt weakness like that, and there's a big difference between perceived weakness and overt weakness. You're normally pressing 150, 160 overhead, and you put 65 pounds on the bar and you can't get it overhead with that arm, that's overt weakness. If you're normally pressing 160 and then you normally do it for a set of 3 and you only get it for 1 today, that's perceived weakness, right? That's not overt weakness.
I believe, whenever you have overt, just real quick, I believe on the day that I discovered the injury, I believe I was supposed to do 180 for 6, and I maybe got the bar overhead. I definitely didn't get my first warm up of 95 overhead. I just went like that, didn't go, and I put it back down, and the gal at the rack next to me, the owner of the gym, Rachel Fox, she's like, are you having a heart attack or something? It was really strange.
Yeah. And so that was why whenever you called me and you told me that, I was like, all right, look, man, you've got to go to a neurosurgeon. And so do whatever you got to do to get in to see a neurosurgeon. And then obviously, you went and saw the neurosurgeon and they agreed that this was urgent. And so they got you in within 48 hours, I believe.
The next day.
Next day. Yeah. So typical protocol, whenever somebody has what you had, just an anterior cervical discectomy and fusion, is used to, they would put you in a collar for 6 weeks. Now it's much more common for them to either put you in a soft collar for 2 weeks. And there's some neurosurgeons that don't put you in a collar at all. I think in your case, you were put in a soft collar just because the neurosurgeon probably understood that you were probably going to push the envelope a little bit. And that was some modicum of protection. Because, if you just kind of look at the physics of it, you're a big guy, you have a big head. And so they put this plate in there, and then you've got the bony fusion, the little strips of bone that they want to create the bony fusion. And just physics, you're a big guy. And so whenever you move, there's more forces going through your neck than there are somebody with a neck like mine, right? So they put you in the collar for 2 weeks. And the big thing starting out with you was knowing the psychological impact of immobility for you. It was, let's just get you doing whatever you can do. So once you had your first post-op appointment and there was no signs of infection, then we got you to where you were riding the air bike and you were going on walks, which I know for a guy like you, you've trained Thai boxing, Muay Thai, you've done martial arts for, I don't know how many years. You're an experienced trainee. Like, being programmed to go on a walk was probably not the best for your mental health, but it at least got you doing something, right? And then we also started you with partial range of motion. So the first 2 weeks we had you doing just partial range of motion along with the air bike and the walking. So we just had you doing 25% range of motion. So just to get you moving, but not anything to stress the potential fusion. And we did that for 2 weeks. And then at the 2 week mark, whenever the collar came off, that's whenever we started with the empty bar. And with bench press and overhead press, I think you started with the 10-pound bar. Whenever I first programmed that, I just programmed you like just open weight, like find what you can do easily. And I think you first tried the 20 kilo bar and you couldn't move the 20 kilo bar. So you had to move all the way down to the 10-pound bar. And you started that on the second week, going into the third week. And that's what we started with. And because it was 10 pounds and it was no stress, There's no stress. Then we did higher repetition, which is something I don't normally do. I normally do higher weight and lower repetition, but whenever you're so artificially limited on how much you can lift, then at some point you have to add stress somehow. And so we were using high repetition just to work on the motor function and the motor control, because prior to the surgery, you couldn't even move your arm in a coordinated manner overhead. Like, I mean, it was actually kind of sad watching you try to lift your arm overhead because of how you had to like compensate to try to get your arm overhead.
It gets stuck. Remember, there was like a catch right around here.
Yeah. And then you could kind of like shift and you could compensate, and then your arm would go up, but it wasn't coordinated. And so you could almost see like different motor units, like trying to get involved in the movement, and they weren't there. So then the body would have to pull in something else. And so you had just these really uncoordinated movements. So we started with the bar and we just did sets of 10. That second week, we were able to go up 5 pounds, and we had your head supported on the bench because I didn't want you pushing your head down into the bench if it got heavy. So we elevated your head with a folded towel or something like that, just to keep you in a little bit of flexion. Because right after an ACDF, flexion is a safe movement, but in range extension or resisted extension is really not. So elevated your head, cued you to maintain a soft neck whenever you're pressing, because I didn't want you to extend up, and I didn't want you to bear down into flexion whenever you're pressing. So the cue was just to maintain just a soft neck, and you did that well. And then on week 2, whenever you first started benching and overhead pressing, you were doing the 10-pound bar for sets of 10. The second week, we moved up to the 15-pound bar, and you did sets of 10 on that. And then you went up to the 45-pound bar. So on the third week of training, you're already back up to the 45-pound bar. And it's interesting going back and looking at your rehab feedback, because the first time that you did the overhead press with 10, like your feedback was, wow, that was a lot harder than I ever expected it to be. Mm-hmm. And then you did the 15-pound bar the next week, and you're like, it wasn't bad, but it was still relatively hard. Then on the third week, you blew right through your warm-ups and went right up to the 45-pound bar. And then that was easy for you. And so and at this time, I think people probably should know that like we were talking before we started recording, is I wasn't programming you for a week at a time, or I didn't template your rehab for a month or 2 months. Like, I was programming you day to day to day to day. So I'd program you for what would be tomorrow. We'd see what your performance was. I'd look at your videos. We'd communicate back and forth, and then you would get programmed for the next day. So this was day to day to day programming. Got you up to the 45-pound bar at week 4. You started progressing linearly at that point, and then at the 6-week mark, that's whenever you had that kind of the second epiphany stage, where all of a sudden you went from benching like 75 pounds to now you're up at like 115 or 125. Like, it just shot up, which makes sense because tissue heals, and usually about the 6 month or the 6-week mark is whenever you have the majority of the healing that happens. And so we were able to take advantage of that because we're following you day to day. And we're looking at your warm-ups, and you were communicating with me on Signal as you were getting into your warm-ups and stuff like that. So we were able to take advantage of these little spots along the way where you had increased function. Still 125 pounds for you is not a whole lot, but that's what we could do at that time. And then at that point, then we started moving pretty much linearly on your pressing movements. But at this point, we weren't pulling, and we weren't squatting. So that didn't come into effect until the 8-week mark. So whenever you're 8 weeks post-op, that's whenever we layered back in the safety squat bar and the deadlift. So we started having you rack pull and pull from the floor.
That was a long 2 months, Will.
Yeah, I know. And it sucks. And I do remember some of our conversations back and forth trying to get you in the right headspace about your rehab, right? So a lot of it is positive reinforcement, like trying to get you to see where you were compared to other people that have had similar procedures done or something like that, right? I mean, at 6 weeks, 6 weeks, you're doing more than what most people in the country could do on any given day, even people who aren't just coming out of surgery, you know. And so that's a difficult part whenever you're working with injured people or people coming out of surgery, is they kind of always had this vision of who they were prior to surgery, and they see themselves as being somewhat less than what they were, and they kind of lose sight of the journey and how I mean, it was almost fascinating, just like how little attention you paid to your progress over time. Like, you moved from a 15-pound bar to a 45-pound bar, and your only feedback was the 45-pound bar was a little bit heavier than I thought it should be. But it's like, dude, that's 3 times what you did last week. That's a 300% increase. And it was just, but you know, I do think that like that same type of like psychology is what got you to this point in the first place, right? Not as far as the injury, but that's
probably the injury too, actually.
That's probably what made you like seek like maybe perhaps a better way to rehab this. You know, like, you know, your end goal was that you don't want to get injured, which you don't want to get injured again, and I kind of understand that. But at this point, if you ever have a neck injury again, it's going to be a new injury. It's going to be because something else happened to you. I think probably more correctly stated is that you didn't want this particular injury, this particular surgery to limit what your life going forward was going to be, right?
That, and I was pretty worried about the fusion. I was worried the damn thing wouldn't take.
Yeah. And I remember your interval X-rays, and you know, I think at 2 months you had an interval X-ray and it hadn't fused yet, and there was kind of you kind of had a little bit of a moment that it hadn't fused yet, and there was no sign of fusion. But then I think your last one done 6 months, right?
Yep.
Was it the
6 months.
And it was near complete fusion at that point, which is still faster than most people, right? Because even your neurosurgeon said that sometimes it takes up to a year to do it. It did look like starting out that maybe the fusion was not occurring as well as some people at the start, but then it really picked up steam between the 2 interval X-rays, because it went from there's really no evidence of any fusion to now it's near complete at 6 months. At the 8-week post-op period, like you were still, that's whenever we really kind of were able to pin down what the residual weakness was. I don't know if you remember that, but remember how like you were gassing out on the bench press, but it was always the top part of the bench press. And whenever we do like the banded exercises, because we were doing that kind of to start out with, we were doing kind of back and shoulder focused band work because we could keep you in a safe position for your neck, and it gives you, you know, some resistance or stimulus for your back and your shoulder. But once you got to about the 8-week mark, then we were able to see that you did have some residual tricep, bicep, lat and pec weakness. And so what we started doing, we started layering in accessory lifts at that point, you know, and then we started making changes to your programming to where we weren't doing like straight sets across. Instead of doing 3 sets of 5, we would do something like, you would do like a 3+2 set, because you would tend to fatigue out at the end of the set. And that would limit how much you could do for a set of 5. But if we had you do a set of 3, we could have you do it heavier, take a short break. I mean, like 15, 20-second break, lay back down, and then do 2 more reps. And then those reps were still challenging, but you weren't failing on those. So we were able to get more challenging reps completed by having you do the plus sets. And I think that was probably the one program modification that we made between the 8 and 16-week mark that continued your progress, other than just layering in the squats and the deadlifts. And then the accessory work, I mean, accessory work is useful because it kind of adds some variation to the workout and stuff like that. It kind of makes you feel like you're doing something, but I really still think that the heavy barbell work and just modifying the sets and reps so that we could get you to do more volume over time was probably what drove the progress there.
Yeah, that was a painstaking process, and the real mental challenge is, I don't know if it's just me being neurotic and having really high standards. You tell me if you see this with yourself or with your patients, but whenever I experience an injury, especially, so actually I make a distinction between being hurt and being injured. Being hurt is fine. Hurt just means I'm experiencing pain, and being injured means to me, and correct me if there's a clinical definition I'm screwing up here, but injury from my point of view is you've actually damaged something, whether something in your some musculoskeletal issue has happened. So being hurt is just part of being a fighter. It's part of being a strength trainee to an extent, to a much lesser extent. It's part of being an active person. It's part of being a human. Even if you're not active, you're still going to get hurt. Being injured, though, can be a bit of a mind fuck, because when an injury happens, you always are curious, well, how bad is this? And how long is it going to last? And are things always going to be this way? Right. So I didn't know what to expect. I had the surgery, and then I went to overhead press, and I felt weaker than before the surgery. I'm like, man. And I remember the relief. It might have been the 45-pound bar jump or whatever it was, but the relief where it's like, oh, it's coming back, and it's coming back fast, and that brilliant, simple, linear progression, even though the sets and the rep scheme changed for us, is just such a valuable, useful thing in so many different situations, including this. And then, meanwhile, I don't have any aggressive physical outlet. And just for me, psychologically, I have to have that to feel normal. And I think there's a lot of men like that. And I know young men especially need that. Like, I can watch a kid who's got behavioral problems join jiu-jitsu and all of a sudden become a good little kid. So it was just challenging. And, I didn't know which direction it was going to go. I didn't know if my arm would atrophy. I didn't know if I'd have lost function in my left arm. I didn't know if my neck would fully heal and I'd be able to get to almost normal function. And I'm just kind of waiting on pins and needles while dealing with all the stress of not being able to blow things out physically. So I was just doing my very best to be patient. And this required a lot of patience. But fast forward to today, it's the end of June 2022. I just finished my 5th jiu-jitsu session. I'm not training with the competition team anymore. I'm in the beginners fundamentals class, and I'm drilling with my brother only, and he's not touching my head or my neck, and I'm not doing any front rolls. I'm not putting any pressure on my head or my neck. I'm just learning jiu-jitsu slowly and carefully. And then I'm back in the gym lifting reasonably heavy weights. To the extent that my body composition is improving again, because that was all that stuff happening at the same time. Plus I'm getting soft and I'm not able to enjoy food. It's just like layer upon layer upon layer of issues, because everything is so interconnected with health and fitness and diet. But yeah, here we are today. So what happened next? Well, what that was kind of phase 1. How did you think about things beyond that, and how did we end up where we are now?
Yeah, so it was I have a note on here that it was at the 10-week mark. At the 10-week mark, you kind of had this like seminal event in the gym. You were programmed 3 sets of 3 for 100 on the overhead press, and for some reason you wrote that down as 3 by 8, and you went into the gym and you did 100 pounds on overhead press for 3 sets of 8, and that was kind of like this like seminal moment, because the press had been the one that had been lagging behind the most. And then all of a sudden we were moving you up kind of in an incremental fashion. Then you went into the gym and you did 3 by 8. You did 24 reps at 100 pounds, and it was easy for you. And so that kind of jump started your press progression. And then it was 8 weeks later, I think you pressed 170 or 175 for a set of 3. And I think that was the highest that we got you up to, because then, you took about a 4-week break where you had some personal stuff going on and you were traveling a lot and stuff like that. So then by the time that started, we had you back to near almost 300 pounds on the bench. I think the highest you did was 290 on the bench, something like that. It was like 285, 290, something like that. But you were right at the cusp of 300 pounds, which I don't think you'd ever benched 300 before, right?
No, I'd never done a heavy single. I think I've gotten my bench to where I could probably do 300 for a single, but I just never practiced heavy singles.
Yeah.
I'd like to. That'd be a cool accomplishment. I'd love to do 3 plates too.
I mean, I think we could probably just get you back to doing heavy singles at this point, and you've probably got more than enough strength in the tank to be able to do that. But once all of that happened, and then you came back, then your goals kind of changed a little bit, and your rehab changed because at this point it's not really rehab because you've gained virtually all of your function back.
Mm-hmm.
Your range of motion in your neck is perfect. You've got complete fusion. There's nothing else that needs to happen whenever it comes to rehab. So now it's just basically strength programming and just knowing what you can't do or what's not advisable to do. And whenever you came back from that, then we kind of changed your program. Now, instead of just doing a pure strength program, we're kind of doing, I think probably the best way to describe it would be a wave loading program. So you're doing a week of higher repetitions. The next week you go down and we take some repetition away. And so you go up and load, and then you do that again. And then we're just flip-flopping between sets of 8, sets of 6, sets of 4. The next time you come in, we increase the weight again, but it's all percentage based. So we're still, every single time you come in, whether you're doing 8s or whether you're doing 12s or whatever the prescription is for that week, for that wave, the last probably 3 or 4 reps of that set are going to start getting really hard. And so that's what we're doing right now. You've been doing that for about 5 or 6 weeks now, and body composition has changed. Your strength has stayed pretty even to what it was whenever we're just doing a pure strength program. There's been a significant amount of hypertrophy that's gone on during that time, which I think that's something that I've noticed too. Whenever I've trained somebody for strength for a long time, they have a good foundation of strength, and then they decide that they want to do something more like hypertrophy based. You switch them to a hypertrophy type program, and it's almost like all of that accumulated strength and all the architectural changes of the muscle that happen whenever you train for strength. Then whenever you switch to a hypertrophy program, it's almost like the body's just primed to get bigger. And I mean, at this
it's strong
point,
enough to lift a heavy enough weight at high reps for it to actually have the right stimulus and produce a response, right? Otherwise, if you're not strong and you're doing a bunch of bicep curls, it's like it's not enough of an insult to cause an adaptation.
Perfect example. So, I mean, I had bicep surgery in March because of my proximal bicep tendon, and they released the proximal bicep tendon. They did what's called a tenodesis. So they just fixated it to my humerus here, and it was back in the gym and everything was going great. Carried my daughter to bed, and whenever I laid her in bed, the tenodesis failed. And so the tenodesis tore. And so now I've just got my long head of my bicep is just kind of living somewhere around here.
Let's see it, man. Is it missing or what?
No. So I've got what's called a Popeye deformity, which is kind of funny. I mean, I don't really give a damn, but I guess you have to compare it side to side. So on this side, this is the divot between my deltoid and my bicep, right?
Uh-huh.
On this side, it's significantly larger.
Oh shit.
So this, I'm sorry. Yeah, this. So it's about 3 finger widths, and then like the long head of my bicep is like kind of like residing down here in my elbow now.
Oh wow. And you're just gonna leave that alone, right?
Yeah, no, there's no reason to do it. So if you look at the outcomes whenever you do a tenodesis where they fixate the tendon versus a tenotomy where they just release the tendon and just let nature take its course, the outcomes are pretty much exactly the same. Yep. Strength remains the same. The only real reason to do a tenodesis is for cosmesis. And I mean, I'm an ugly dude and I'm never going to be a good looking dude, so it doesn't matter. But
you don't have an arm deformity show coming up. It's fine. Yeah.
An arm deformity doesn't change anything for me. But all that said, since I had to start doing more rehab for my bicep, because anytime you have surgery, like you do have to try to kind of build things back. I mean, at this point, I'm just coming up pretty close to 4 months. No, I'm sorry. I'm 3 months post-op. 3 months post-op, I can go into the gym and pick up a 60-pound dumbbell and curl it with this arm. And now that I've kind of gotten my strength back, and I never did curls before, but now 3 months post-op, because I've been doing more focused bicep work, like I can pick up a 60-pound dumbbell and curl it for a set of 5, 6, 8, something like that. Whereas all the SARMs goblins in the gym with their like broccoli hair, go in there and do biceps every day, and they're doing like 15 pound dumbbells or 20-pound dumbbells or whatever. And like they're trying to build muscle whenever they don't have the requisite strength to lift enough to actually build the muscle. And so,
Andy Baker and I just did a podcast on this that I think you'll enjoy, where he breaks down strength and hypertrophy and how those two things are so interlinked. And he's got a bunch of great examples and ways to frame it. But the way I look at it is, don't put the icing on the cake until you bake the cake, right? Like bodybuilding's icing on the cake. Hypertrophy work, isolation stuff is icing on the cake, but you need to have cake first. Otherwise you're just masturbating.
There's a lot of that. There's a lot of people, like a lot of guys in the gym, like blowing kissy faces to themselves in the mirror instead of actually working. But in the clinic, it's funny because even in the clinic, like I have to wrestle with the bodybuilding mentality whenever people come in, because somebody comes in with knee pain and I'm gonna give them squats, or somebody comes in with back pain and I'm gonna give them squats and deadlifts, overhead press to rehab them. I always get, well, what do I do for my quads? And then I tell them, well, you don't really need to do anything for your quads right now. I mean, you got a 19-year-old active duty Army soldier who's 6'3" and 135 pounds, and he wants to know what exercises he should do for his biceps. And it's like, man, it's like you don't have biceps. You gotta build a foundation first. And so the illustration that I use for people, and it's been relatively effective, it's kind of the same thing, is like if you're commissioned to carve a statue, right? You could do two options. You could either start with a big block of marble and you just use a sledgehammer to just kind of knock away big pieces to kind of get the general shape that you want. And then at that point, then you have this like all these different intervals of chisels. And you're going to start with the big chisel first, because you got to do the big detail work. And then you work your way down to, at the very, very end, you're using, wet sandpaper and little bitty chisels to put the finest detail work in there, Or you could try to work it from the bottom up, where you take little pieces of clay and you try to perfectly shape them and mold them and put all the detail work, and then try to put those together over time to make the statue. And it's like, which one's going to be much more efficient with your time? Mm-hmm. And everybody universally says, well, of course, like you use the marble and the sledgehammer. And it's like, yeah, your strength work, that's the sledgehammer. Mm-hmm. That's going to give you the overall shape. And then you start putting in the accessory work, and you start putting in the supplemental lifts and stuff like that. And that's what gives you the detail work. But you work from the biggest movements all the way down to the lowest movements. And then whenever you're, 2 weeks from getting on the stage or whatever, that's whenever you should be hammering away at, banded deltoid raises and fucking preacher curls and stuff like that. Mm-hmm. But before that, you should probably just, if you get your bench up to 315, your biceps are going to be big.
They're going to be big.
They're going to be big.
Yeah.
And you got to build the foundation first. And that usually resonates pretty well with people. I'm sure Andy probably has a better way of explaining it, because he's far better at this than I am.
He's got a lot of experience with this stuff. Yeah. And basically what it comes down to is look, for those of you guys that are out there and you want improved aesthetics, if you don't have your deadlift in the neighborhood of 500, your squat in the neighborhood of 400, your bench in the neighborhood of 300, and your press in the neighborhood of 200, don't do calf raises. Don't do cable flies. Don't do, what are these, wrist curls? Don't do wrist curls. Just get your lifts up. Just train 3-4 days a week on a program out of the gray book, practical programming. Get your lifts up to at least those numbers. And then if you want to start screwing around with the isolation stuff, you can, because one thing that I found, I've done the experiment for you guys, okay? When I was 19 and skinny, I tried the bodybuilding stuff. It didn't work. Now I'm stronger. I'm being coached under Will, and we're doing all the barbell movements, of course. And then, I mean, really, we're just doing the bodybuilding stuff because of sheer boredom. It's like, I need to make something. I need a number to go up in a way that is exciting for me. And if that is the circumference of my bicep, fine. If that's a subjective view of my aesthetics, cool. But I got to tell you, man, going to the gym for your rehab protocol was seriously challenging. I had to drag my unmotivated, chubby ass to the gym to do a bunch of sub-maximal, boring, repetitive shit. And it got to the point where I was like, Will, We got to do something, man. I'm the strength guy because, starting strength gyms and love strength training, but I'm not setting any PRs right now, and I'm not having a good time. So can we do something to make the gym more interesting for me? Can I at least have, like, if I'm not going to be setting PRs, can at least we have an aesthetic goal? And dude, I think you've got me in the best shape of my life. I'm at 243 right now, which is probably 8-ish pounds less than where I was at right around the surgery time. Stomach's flat, stuff's growing where I like it to be growing. So, I'm 37. I've got a couple years left of having reasonable aesthetics, work with what I've got kind of deal. And I've never actually focused on aesthetics in the gym. And so
define a couple of years left, because I'm a couple of years older than you. I'm not ready to hit the precipitous fall yet.
Yeah. These, whatever I have left of the 100,000 hair follicles is diminishing. The lines are sinking in. The baby's coming in January. So, you care less and less as time goes on, right?
that will age you faster than anything else.
Yeah. Yeah. But yeah, so what else do you want to share about your approach to rehab, or what we went through together? Or, because essentially you're not cheap, right? I paid you $350 a month for 6-7 months. And if you just think about, is that expensive when it comes to hiring a personal trainer or a remote coach? Well, hell yeah, it is, right? But in the context of the amount of time that I spent on the surgery and the amount of money that I spent on the surgery, and the context of function for the remainder of my life, if I pay $350 a month for 6 or 7 months, in the grand scheme of things, it's not that expensive, especially when you're thinking about return on investment. So I absolutely would do this all over again, and there's not much I'd really change. I would just say, Will, I'm in your hands. Tell me what to do, and I would follow your instructions, and that's exactly what I did. And I got to say, it's not just the programming that helped me, because I'm a starting strength coach, but you're a more experienced starting strength coach. And I remember one time I called you from the gym because I pulled a heavy single on the deadlift. It might have been 415 or 420, and I was like, man, that something didn't feel right there. And I sent you the video, and you told me I think I had overextended my neck. I had my upper back was in slight flexion. I hadn't extended my upper back hard enough, which made me compensate with my neck, which caused a little bit of a twinge that worried me. And then you reassured me, readjusted the program, and everything was fine.
Yeah. And, as far as like cost, if you look at the few individuals like in the market that do what I do, like I'm mid-priced in the market. Like I'm not that. There's people who charge a whole lot more than I do, and then there's some people that charge a lot less than I do. So cost is probably, if you average it out, like cost is about the same regardless of where you go. If you average it out, there's some people that's more expensive, some people that's less expensive. The pricing that I have is generally about what you would pay for 3 physical therapy appointments if you were paying out of pocket, 3 physical therapy appointments for a month, because those run about $125 for each session. And so now most people pay a copay or whatever, $25, but a typical rehab session is about $125. And so that's the pricing is about three rehab sessions for a month. Could definitely charge more, but I don't charge more than that because I don't want to price people out of the ability to be able to do it.
Yeah.
And right now I've got a total of about 20 clients. I've got about 20 clients that are on different programs, but
not a bad deal. And then guys like David Berkowitz can afford your services. David Berkowitz, will link to the interview with him and his wife, Pam, but he had what I had times 5. And he's a bit more advanced in age.
His was a two-stage fusion. So he had a previous fusion, and then they had to extend it. He had to extend it. And some other considerations for his particular case that I hope gets brought up whenever you interview him, because his is a very unique. I guess I would say it's a unique case to be presented in a forum like this, whereas it's not very unique in like a physical therapy clinic. We see that particular condition like quite regularly. It is pretty common in individuals that age, but you usually don't see those being discussed on a strength forum. And so his is actually a really cool case.
Yeah, I think you're going to help him quite a bit. I just saw him yesterday and he's in good spirits. So thank you for helping him manage that. I wanted to ask you at the beginning of this podcast, part of my intro was, a bit of an indictment against your profession. Talk to me about physical therapists and talk to me about what outcome I would have and how that would be different had I continued to go see, because when I got out of surgery, I followed the doctor's orders and I went to PT and I was doing a bunch of bullshit. And it was stuff where she said, "Oh yeah, we're going to strengthen your shoulder or whatever." Right. And it's like, I don't think this 5-pound band is doing anything to strengthen my shoulder. I think my shoulder is pretty strong. And I think it's just a one size fits all approach. And my insurance covered 3 days a week of PT for a really inexpensive copay. I don't know, $15 or something per session. But I actually just opted out of that completely and paid you out of pocket instead. Do you have any idea about how things would be for me if I had gone the traditional PT route instead of using someone that knew how to manage my situation like you?
Yeah, I mean, if you want to know exactly what you would be doing, all you have to do is just go to Google and type in Brigham and Women's University rehab protocols, and then pull up their anterior cervical discectomy and fusion protocol and look at the timeline. And whatever that says, that's basically what you would be doing. So I think at the 6-month mark, you would now be cleared for most return to activity type stuff and things like that. But most physical therapists, because of the litigious nature of the medical community, they're going to follow the surgeon's protocol. And in the clinic, that's probably the most likely thing that's going to happen. You probably have some more forward-thinking physical therapists that understand things a little bit better. They have a good relationship with the referring surgeons, and the surgeons are okay with them pushing the envelope a little bit more as long as they're doing so in an educated and safe manner. Like I benefit very greatly from having 2 orthopedic surgeons that I work directly with, and a podiatrist that I work directly with that know exactly what we do, and they encourage us to do what we're doing. So, whenever I sent you that video today of kind of our revitalized or refreshed physical therapy clinic, like that comes at the backing of our orthopedic surgeons to say, this is how I want my patients rehabbed.
What's that called? The monolith? You've got that deal that helps you bench heavy singles so you don't have to bring it over your face. Yeah.
Yeah, I mean, that's the most dangerous part of the bench press, is just getting it off the hooks and bringing it over your face to put it into position. Mm-hmm. And then also, I mean, if you bench with the monolift, I think most people that are fairly experienced can usually handle about 15 pounds or more on their working sets whenever they bench out of a monolift, because you just use a lot of energy getting it out of the hooks and getting it over your chest. Mm-hmm. And that's where the kind of the danger area is. So just being able to get set under the monolift, just push up, the hooks swing back, you're right in position to do your bench. And then whenever you get done, your arms just drift back, they go into the monolift, and then it sets it right back down into place. It's awesome. And then for patient safety, it's great, because now the bar is virtually never over their face. And whenever we're working with people, like we can have them bench safely, we can have them bench heavy. And the only time that the bar is ever over their face is whenever they finish the set and the spotter has their hands on the bar. And yeah, it's great.
Kudos to you for figuring out a justification to get the federal government to pay for a monolith for you.
Oh no, I have pages and pages of documentation of justification for why we got everything that we did. And it's all based on patient safety. Mm-hmm. Mm-hmm. And actually, I mean, I don't even think like it's bullshit justification. That like the justification that I used for that equipment, like I'll stand behind that.
Absolutely. I had the bar coming over my neck that I just had operated on, right? So that's a legitimate consideration.
Like using urethane plates or using competition plates as opposed to cast plates or training weights. Like whenever they're within a few grams of the stated weight, then you know exactly how much is on the bar. There's not the wild discrepancy. Like one 45-pound plate is 42 pounds, another one's 47. Now you've got a 5-pound misload on the bar. So for patient safety, it's much more accurate on either side of the bar. The urethane plates can be cleaned better than something like a vulcanized rubber. Um, yeah, using the power bar instead of whatever cheap bar that they buy through the bulk buy program. Having knurling on the bar as opposed to having it smooth across the center. The racks that we have the west side spacing through the range of motion, so we can adjust at 5/8 of an inch instead of like 3 inches, and all that is based off of patient safety. Like this is, we can have people do more and rehab more completely in a much more safe manner by using proper equipment.
Let's talk about the lifts for a minute, Will, because we talked about the press and what you did for me there with the progression of weights and the reps and set schemes, and then keeping the soft neck. And then we talked about the bench press and how you had me put a towel underneath my collar to support my head. I had to kind of like grab my neck and slowly kind of lay back for the first few weeks. And then the deadlift, you basically ramped up pretty aggressively. And then the squat was something that I am not totally clear on as far as the how and the why. Would you mind explaining how you approach the squat for me?
Yeah, so we had a little bit of an issue with the squat, and this ties in other issues that you had. So I don't know if you've covered it before, but like you have some very very severe elbow pain with squatting, with low bar squatting. Like that's been a persistent issue for you over a long period of time. And kind of no matter what you do, after you get to about 300 pounds, the elbow pain starts to become debilitating to where you can't even squat anymore.
And if I say fuck it and push through and can't use my arms for a day, then my hips cause problems. So I'm an orthopedic mess thanks to the sport right here.
Yes. The tax man's going to come to collect at some point whenever you do things like that, right? But so we use the safety squat bar. So I'm not a huge fan of the safety squat bar, but in your case, it was absolutely the right call to use. And instead of using the normal safety squat bar, you used your own money and purchased a Mars bar, which is a modified safety squat bar, which instead of having a yoke around the neck with the handles coming out this way, a Mars bar kind of conforms to the torso, and it kind of wraps around the top of your torso, and then the bars stay right here. And the reason why we did that is because with a normal safety squat bar, for your condition, just having surgery, and you've messed with the safety squat bar before, right? That if you don't lock the safety squat bar down with your arms, then the bar rotates. And you see it all the time. Somebody starts to squat down, and as they're going down, the handles come up, and so the whole bar rotates back. But then as they come up, the bar rotates forward, and that's what we didn't want. I didn't want the bar to rotate into your neck, because if the bar rotated into your neck, it would push you into flexion, which in the middle of a squat, doing this is going to kind of instinctively make you want to push your neck against the pad to try to push the bar back, because it just seems counterintuitive to try to manipulate the safety squat bar with your arms. So you use the Mars bar instead. And what we did with that was, because you have the recurring elbow issue, what we wanted you to do was keep your arms. So a lot of people, whenever they use the Mars bar, will hold the bar like this. But whenever you're holding the bar like this, one of the motions to keep the bar pressed up against you is going to be internal rotation of the shoulder, right? And I didn't want that, because whenever you fixate the arm and then you try to internally rotate, that causes strain on the ulnar collateral ligament of the elbow, which is what most of your elbow issues with the low bar back squat tend to be, what we call either valgus extension overload syndrome or ulnar collateral ligament pain, just because you're putting a valgus stress on the elbow. So what we did is we had you tuck your elbows into your side hard like this and hold the bar at almost like a 90-90 position for your elbows.
Yeah, because real quick, well, so I without your instruction, I would kind of flare my elbows to leave room for my torso to go in between my legs so I could low bar squat, because the Mars bar puts the load in kind of a low bar position so you can bend over with it. And so I was kind of flaring my elbows so I could get into position, but then I would lose rigidity in my upper back. And then your cue to kind of squeeze my elbows into my torso and extend my chest and then pull down on the bar, locked it into place, and my whole spine was more rigid as a result. So it was great to have your coaching on that.
Yeah. So instead of internal rotation of the shoulders to lock it down into place, whenever you're here and you're pulling the bar into you, you're engaging your lats because that's pulling you into shoulder extension. And so the shoulder extension, and there's going to be a little bit of internal rotation, but that's not the main movement. So you pull in like that engages your lats more. The lats kind of act as the linchpin for your back whenever you're setting your back, which is why we cue people to engage their lats or to pull the bar into their legs whenever they do a normal deadlift. And so for you, we were able to progress the squats like pretty effectively. I think we got up to 3x5 at 275 with the Mars bar.
Mm-hmm. I think that sounds right. Yeah.
I think that was about as high as that we went. And then that was about the time that you went on vacation and you had that time. And then we run into the problem that whenever you came back, whenever we're doing the program that we're doing now, is that you don't have access to the Mars bar at the gym that you go to. Mm-hmm. And rather than giving you low bar back squats and potentially aggravating your elbow, we're trying to find other squat variations to kind of give you a little bit of different stimulus. And so we've been using the cannonball squat for the last 3 weeks, and we're going to pull that away and then use something else for the next 3 weeks, because that can be pretty stressful whenever you do it over a long term.
Mm-hmm. And guys that are listening to this and are looking for exercise variety to solve boredom, don't do it. If you're in a specific situation like this and you need to switch things up for psychological purposes or for rehab purposes, you've got all this exercise selection at your disposal. But if you're trying to get stronger, don't cannonball squat. Just if you can low bar back squat.
No, it's a terrible
low bar back squat.
It's a terrible exercise for strength development. But whenever we're trying to our focus is hypertrophy and making you still work hard with a lower weight, then yeah, they're totally fine for that. I mean, they're very great for developing the quadriceps, but they're very, very hard on the anterior structures of the knee and the quad tendon. So you can't do them for a long period of time. Good to throw into the program for a 3 or 4 week block and then move away from them. And then you got to switch something else out. And then that becomes a problem whenever you start trying to complicate your program, is that people will complicate their program. They'll throw a bunch of accessory lifts in there, but they're not really understanding like just how long you should do certain exercises. Some of these more isolated or kind of these more specialized exercises, they're not really useful to use for a long period of time. Use them for a short period of time because you want the increased stress, but you can't tolerate that increased stress for a long period of time. So cannonball squats don't need to be part of your program for, the next 6 years so that you can get, some quad sweep. It needs to be something that you do for 4, 5, 6 weeks at the very most, because your program has changed where you need some extra quadricep strain or stress, but you don't have access to another piece of equipment that would be better. Like I'd much rather you do a belt squat, but you don't have access to a belt squat. So we have to make a decision there. And so we're going to switch that out for something else this upcoming week.
Let me know if you need me to find a place for the belt squat, because just tell me what is most ideal and I'll do my best to find a way to get it done.
All right. Yeah. And then like for your squat progression, we never really got to the point where we were doing really heavy singles with the squat because we didn't need to. The Mars bar, as good of a equipment design as it is, it still is not nearly as good as squatting with a regular bar. I mean, for myself, I can squat in the low 500s pretty much any given day of the week. But whenever I put a safety squat bar or a Mars bar on, like I'm squatting in the high threes. So, I mean, there's more than a 20% difference between what I can low bar squat and what I can use with a safety squat bar. I mean, a 350 safety squat bar squat is really, really heavy and really hard to manage.
It's a it's a clunky device. It's kind of hard to keep things as tight, and the standard barbell is the solution if you can manage it.
Yeah, after shoulder surgery, I mean, I could not get the bar on my back. I could not get my arm back far enough to low bar squat. And so now I'm kind of doing a little bit of kind of like a bastardized high bar, low bar squat, because I'm still missing about 20 degrees of external rotation on this arm. And so it doesn't get back quite far enough to squat really securely. So I've had to change my grip. Like I'm using a Talon grip now. So I'm actually grabbing the bar like this with just 3 fingers over the bar instead, because that gives me a little extra mobility to get back here, and I can kind of wedge my arm in there a little bit better.
Wrap thumbs, just not or thumbs on top?
No, thumbs and pinky finger under the bar.
Thumbs and pinky under the bar, wrists are bent.
Yep.
And just kind of a light grip.
Yeah.
Gotcha. And that's forcing you to kind of tuck your elbows under the bar and get your shoulder blades as tight as possible.
Yeah, because if I put all of my fingers over the bar, like I have to be way out here. Like my hands are almost on the barrel end of the barbell just to get it low enough. And then at that point, my elbows are pointed way far back, and it's just not comfortable and pretty limiting, because at some point, like you just can't get comfortable enough to think about actually doing the set. You're just constantly thinking about trying to readjust the bar. But by modifying my grip a little bit, I can get it pretty close to what it should look like. And so, if you've looked at my Instagram as I've kind of documented this, the first couple of squats that I did looked very much almost like I was doing a high bar squat, or like a back squat equivalent of like doing a full Olympic clean. So if you just imagine doing a full Olympic clean, but just the bar being right here at the base of your neck instead, that's what I was doing, because that's as far down as I could get the bar. And so I was doing less weight than I could do low bar squat, but I was doing more repetition, and I was increasing the range of motion, because that's how I was balancing out the lack of stress on the load by adding a little bit more volume and a little bit more range of motion. And then as my shoulder got a little bit better after surgery, then I was kind of always trying to push the envelope to get myself back into a low bar squat position. And at this point, I'm probably about as far along as I'm ever going to get. I don't know if it's really realistic for me to get much more. And so now it's just a function of getting more secure with that modified grip. But like with your squat, we couldn't progress it the same way that we did everything else, because you were limited by the equipment that you were using.
Isn't getting older fun? And by the way,
it's weird.
Oh, by the way, I was going to say, it's nice now that you've changed the program so that I can train when I'm on the road, because during the days when I had to use a safety squat bar, I mean, I couldn't even train in my garage. I had to go to Starting Strength Boise, which is great, but it's a 30-minute drive. I like being there, but sometimes it's nice just to pop into the garage or go to Crunch down the street and do some bro stuff, and it just depends on the workout for the day. And I have to also say, speaking of which, since I wasn't able to set PRs, it was nice to work isolation movements to failure. Actually, I enjoyed it. I enjoyed the hard work of having a rep almost fail and then going after another one with almost no stakes, getting a little bit of a pump, which admittedly I kind of enjoy. And I mean, it's something hard physically. I was just so excited to do something hard physically again, because it's just like it's missing from my life. So that's been. Thank you for being flexible, is what I'm trying to say.
I think that might be something that like people should know too. Like if you're going to do that type of a program at some point, like I mean, everybody's going to drift back to that, even if it's for a short period of time. Like just the monotony of strength training. I mean, I trained exclusively squat, bench, deadlift, overhead press for the better part of a decade, with only brief periods of time where it was kind of like you, like I'm on the road and they don't have the requisite equipment needed to do whatever. So you just go into the gym and you get a workout, or you cut out of work a little bit early and go to the gym, and there's too many people there. So you just do what's available. But just because you're doing a hypertrophy program does not mean that your program is easy.
Right. Not by any means.
Your program is very, very difficult. Yeah. It's very hard.
I'm enjoying
There's nothing easy about it. doing a set of or 3 sets of 8 at the end of your bench press, doing ramping sets to a top weight of 3 sets of 8, if it's programmed appropriately, like that last set of 8 is freaking miserable.
Mm-hmm.
And then doing your upper body hypertrophy work at the very end of the workout and taking 1 set to failure and doing kind of like a Mike Mincer or Dorian Yates, like 1 set to failure, where you do as many reps as you can do. As soon as you kind of hit failure, you take a short break, do as many reps as you can. I think some people call those myo reps. This is Dorian Yates training. Mm-hmm. Like you're just training like Dorian Yates, but it's extremely hard. It's extremely hard. And a lot of the feedback that you've given whenever you finish was, man, I was freaking tired at the end of that workout. Mm-hmm. And that's what separates your program from a lot of what you see in the gym. Like, no matter what you're doing, it has to be hard. It has to be hard. And you asked the question about physical therapy. That is the main issue that I have with physical therapy. You could potentially take lower level exercise and make it effective, but it has to be hard. But if you're trying to get somebody to keep coming back to physical therapy and you don't have an engaged patient population, that these are not self-selected patients that want to get back to function, or they want to speed up their rehab. They want to get back to something better than what they were before their injury or before their surgery. You have to, in order to keep the doors open, you have to give standard of care, but you also have to deliver it in such a way that somebody will come back. Somebody comes into my rehab clinic and they're not engaged. They don't have the mentality where they want to work hard in physical therapy. If they want kind of like a spa experience, right? They want a hot pack and they want somebody to rub their shoulders and all that kind of stuff. If they come in and I make them do,
these are armed forces, by the way.
Oh, there's a lot of that. There's a lot of that. I've said it before, and it's not an indictment on the armed forces at all. It's a product of the system that we live in, that working as a medical provider in the military system is very, very similar to working in a workman's compensation clinic. The experience is almost identical. Now, I mean, if you were a medical provider for like a special mission unit, or you're at someplace in U.S. Army Special Operations Command, like if you work with SEALs, Rangers, United States Army Special Forces, something like that, those individuals are like multiple time volunteers to get where they are. They volunteer for the military, they volunteer for airborne school, they volunteer for the special operations training, the qualification course, the follow-on training. Like, those individuals have a vested interest in staying where they are. If you look at the rank and file, I mean, there's a lot of benefit to being injured in the military, because potentially you don't have to show up to morning formation because you're injured. You're not going to run. So you know what, just go to the gym in the morning or something like that. Get out of doing work that you don't want to do, potentially get out of field training and stuff like that. So even though we don't want to, we do incentivize individuals to be hurt. And so whenever some people come into the clinic, and it's probably 50% or maybe less individuals who come into the clinic with an injury, like they don't have a vested interest in getting better. There's a benefit for them to be limited. And so whenever they come into the clinic, like, there's no way I'm going to be able to convince them that they need to work hard, that rehab should be like, they should earn their function back. They come into the clinic and they want to be pampered. It's 2 hours to get out of work. You come in, you get a hot pack, you get somebody to rub your shoulders. You do some light exercise with TheraBand, and it gets you out of work for 2 hours, and they're totally fine with that. So the mentality comes into play. And whenever you work in the civilian world, depending on where you're at or who your main referral source is, you may not get a whole lot of people that come in that want to work hard. So physical therapy is always going to be limited because of the expectation of patients and the expectation of surgeons.
Yep.
The idea of first do no harm, it's going to be over accentuated to don't work my patient too hard.
Right.
But what's not going to be taken into account is do no harm can also be don't do enough for my patient.
Yeah.
Don't do
Harm
enough for
could be
my
not
patient.
providing enough stress, right?
But that's, I mean, how many times have you ever heard of a medical provider being sued for malpractice for not getting them back to function?
I mean,
Right? That they
right.
didn't do enough for me. I mean, certainly in the medical field, somebody misdiagnosed or they didn't run a diagnostic test or something that was indicated. That's something else. But you never hear of a physical therapist get sued because they didn't progress somebody enough. You hear of physical therapists getting sued because they progress somebody too much.
Yep.
And
so their incentive is to take it easy and to take the safe route.
Yeah, I mean, it's a safe route because everybody will say, first do no harm.
Yep.
And like I said, it's do no harm by not doing too much for my patient. Don't push too hard.
Yeah. Because your liability is based on your actions, not your lack of actions in most cases. So you have an incentive to...
Your liability is going to be based on what your peers say. So if I got brought up on a malpractice claim because of something I did in a privileged setting where I was working as a healthcare provider, and I went to court over it, what they're going to do is they're going to pull in another physical therapist that has a board certification like I do, and they're going to question that person. They're going to ask them about what do they think in their professional opinion of my rehab program. And since I'm fairly unique in how I do things, what is the normal orthopedic clinical specialist going to say whenever at the 3-month mark I had somebody low bar squatting after an ACL reconstruction?
Yeah.
They're going to say that's not standard of practice. That's not what I do. And then that's where I'm going to be held liable because I don't do what this guy does.
Even if you help your patients more than the standard situation, if you dare deviate, you expose yourself.
Yes. I mean, there's definitely a risk for it. So, I mean, I have to carry malpractice insurance. Luckily, I've never had a malpractice claim. Most of my patients are very happy with the care that they get. My clinic here, we've migrated more towards much more advanced, like functional based rehab. So almost everybody that comes in gets squats, they get deadlifts, they get some variation of those or the pressing movements. But it does come with a fair amount of patient education that we give the patient a choice. We say, look, I mean, here's the situation. This is what you have. We've got 2 options whenever it comes to your rehab. I can treat you in a more traditional rehab approach. We can do TheraBand. There's this whole rack of pastel colored dumbbells. We can have you do some things with those. We can have you get on a treadmill. We can have you do an arm bike. We can do all these like normal things, have you hold a body blade and like shake the hell out of it for, 30 seconds.
I'll waste your time as much as you want me to. Just tell me.
Yes. And I on occasion, those words have come out of my mouth. I've said, look, if you want to waste your time and you want to be treated like that, like I'm perfectly happy with doing that because, you talked about evidence-based practice. One of the pillars of evidence-based practice is patient values. If the patient, that's what their value set it is, and that's how they want to be treated, then you kind of have an obligation to do it. Am I doing any harm by treating this person with body blade and BOSU exercises? Probably not. Probably not. Are they getting maximal? Are they getting maximal function back? Definitely not.
Right.
But if the patient's value is not to get back to full function or increase their function to what it was pre-injury, then I'm giving them what they want. Yeah. But then I say the other thing that we could do is we can actually kind of treat you like an athlete. We can have you back to lifting weights. We can have you actually train harder so that whenever you get done with your rehab, you are going to be more capable of sustaining the rigors of military training because you're going to be bigger, you're going to be stronger, you're going to be more conditioned. We can do that for you too. So the choice is up to you. You just tell me which way you want to go. And I mean, it's probably an 80-20 split. You probably have about 80% of the people will choose the more advanced stuff. And then you have a lot of people that even at that point will say, I'd rather do the other way, the traditional rehab approach.
I'm really happy here. It's 80% to take the hard route. Because it seems to me that
that doesn't mean that all 80% of those or 100% of the 80% complete their rehab, and that they don't drift back into that. I mean, at that point, we're probably 6, 7 out of 10 people that come into the clinic, like they get better. And then there's also a lot of patient education. So individuals that don't want to get function back, you do try to educate the person on kind of the lifelong ramifications of taking the easy approach. Like you're a 20-year-old with some anterior knee pain and you don't want to run. I understand that. But here are the ramifications of being 20 years old with some patellofemoral pain syndrome knee pain and already starting to take away physical activity from your life. These are the lifelong ramifications for that. And so you can turn some of those, but I mean, there's some people that you're never going to change that. And so getting back to the very beginning of this recording, whenever you were talking about your mindset going into the rehab process, I mean, that's far more than anything that I do, far more than any knowledge that I have as far as the rehab process. That's the key variable there. That whenever somebody wants to get better and somebody wants to improve, and they will look for any way to do that, those individuals are always going to have a better prognosis than somebody who doesn't do it. And it's definitely hard. You mentioned it too, that you have an injury and you start worrying, like, how bad is it? How much is this going to affect me over the long term? I think I understand rehab pretty well. Whenever I had surgery and I got back into the gym and I was finally cleared for strength training, and I realized that I was not benching 400 pounds anymore, like I even had that thought, like, shit, like where am I going to top out after this? Like how low did my ceiling go just from having this surgery? And I'm looking at my arm and it's all atrophied, and my range of motion sucks. I can't get the bar on my back, and it's like, damn, I'm never going to squat again. And so even somebody who at least thinks that they know this pretty well, like I had to fight those same thoughts.
Yeah, stuff that I would reassure my clients about. I'm having the same things leak into my own head, and I'm like, shit, this is interesting.
Yeah, and I'm sitting there having this mental struggle with myself. I'm laying in bed at night trying to go to sleep, but I can't sleep because I'm over here thinking, man, did I set my last PR ever? Like, am I ever gonna PR again? And
it's rough.
Yeah. But then that's whenever you start going back to the data. And that's what I try to do with you, is go back to the data that you're accumulating, looking at your program, looking at your completed workouts and seeing the progress over time, and looking at the rate of progress, especially whenever you hit these periods where your progress increases rapidly. And then that's what kind of helps turn that tide. But you have to have the right mentality to get better.
Yep.
If you come out of surgery and you think, well, my doctor told me I'm never going to run again, and you believe that, then the answer is you're probably right.
Self-fulfilling prophecy.
If you think about it, I mean, we have triple amputees that get back to running. They get prosthetics. And I mean, despite what everybody wants to say on, YouTube comment sections, running with the prosthetic is not cheating. Right. It's actually far more difficult to run with a prosthetic than it is with a natural leg.
Could you imagine the miserable jackass that comments on a YouTube video of a guy running with the prosthetic saying that's cheating?
Saying that it's cheating because this individual has some engineer created this, and you're like, no, okay. That's not even close. The energy return on a carbon fiber blade prosthetic is like 60 to 80%. So you put 100 pounds of pressure into that, it's going to spring back with 60 to 80 pounds. You don't run, but whenever you run, you're going to get 300% energy return from your calf complex. And so people with prosthetics are at a great disadvantage. Plus, it really hurts to run whenever you're an amputee and you have a prosthetic, because the weight bearing surface is the socket. You don't distribute the weight bearing through your feet and multiple joints. It's now like the residual limb that's fitting into the socket. That's the weight bearing surface. Yeah. But we have people that get back into running all the time. There's individuals that have gone back to combat combat service in special mission units that are amputees.
Mm.
I mean, if you want to look at something that's like really, really interesting, is look at an individual named Brad Hollings. Brad Hollings was a special mission unit operator who fought in the Battle of Mogadishu in 1993, and his helicopter was hit by an RPG. And they didn't crash in the city. They actually had a hard landing back at the stadium. And whenever the RPG hit the helicopter, it sheared, I think, his right leg off. Oof. But this is in the early 90s, and prosthetic technology was not great. But he got fitted with the prosthetic, and he went back to service for several more years with the special mission unit. And now he runs one of the largest, most progressive prosthetics companies in the entire world.
Damn.
And I mean, at another individual, Colin Rich, got shot in the back of the head in Iraq, and he was legally blind, and he went back and served with the 82nd Airborne as a sergeant major in combat.
These are the people we need in the military, not these.
We have a lot of people like that. Don't get me wrong. We have a lot of people like that. But it is probably getting way off tangenty at this point. But one of the interesting things that you'll read, and you kind of see this type of psychology whenever you look at the boards, you look at the starting strength boards, you look at the starting strength Facebook page, and somebody posts a question about an injury. Almost universally, somebody's going to say, I have this going on. Has anybody ever dealt with something similar? And like just that line, it's almost ubiquitous to all of the injury posts on either the starting strength forum or the Facebook post. People will have like anterior knee pain whenever they squat, and they always follow it up with, has anybody had anything similar?
Nope.
Because there's always this thing that whatever you have is like a completely unique injury that nobody has ever seen before. And people are just kind of like, there's like a draw to having something that nobody else has had.
Special snowflake syndrome.
I mean, I wouldn't want to use the term snowflake, because I mean, that term gets used all the time, and I kind of really just dislike how frequently it's used. But that kind of like speaks to the psychology, right? Like I go and I squat and my right knee hurts at the front of my knee. The first thing that most people should think is, I probably did something different than I normally did. Mm-hmm. That I subjected my body to a stress that has not previously adapted to. I need to clean up my technique. So let me go to the video and see what happens. But you see, it's exceptionally common. Somebody has knee pain. They're on their linear progression. They're on week 3, and they're at 105 pounds on their squat, and they have a little bit of knee pain. The first thing they do is they jump on the board and they want people to comment on, has anybody ever had any knee pain with squatting? But you know what they don't do? Nobody gets on there and has knee pain going downstairs and then jumps on a Facebook community group saying, hey, I was just walking down the stairs and I had a little bit of knee pain. Has anybody ever experienced anything similar? Mm-hmm. It's almost kind of like a unique mindset whenever it comes to training. And I've said it before that I think that one of the problems with training and training injured individuals is a lot of people have this mentality where they're always looking for the off ramp. They're always looking for the exit ramp. They're looking for they know they should be training. They start training, but everybody's kind of looking for that excuse. I say everybody, I don't really mean that, but people throughout the training population, they'll start training, they'll have something happen, and then that becomes the exit ramp.
And that's how training's not for them. Because if you can't deal with the speed bumps.
I did starting strength for 6 weeks, but I started having this knee pain, and like now I just can't squat because every time I do it causes me knee pain. I mean, that goes back to what you had. You had this issue, you started asking for information, but you were asking for information about who can I talk to, who's gonna help me get better, not who's gonna tell me that this is not for me anymore.
Right. Yeah. How can I? What excuse is there for me to sit on my ass, become a victim, and accept that I'm now a diminished version of myself? That's not happening unless it has to happen. And then if it has to happen, I'm still going to max things out as much as I can to get as much out of this life that I can. And the physical part of my life is, it's, I understand what Rip says when he says strength is the most important thing in life. This is true, whether you want it to be or not. And if those words don't ring true to you, then you haven't gone through the process of getting stronger. And if you have, you haven't thought about it long enough, because it is spot on.
Yeah. I mean, at this point, at 40 years old, I look around and I look at my peers. I look at my peers in the military. So fellow field grade officers or senior NCOs that are about my age. And I mean, I don't say this. I guess I should say this. I try to say this with as much humility as possible, but there's not a whole lot of 40-year-olds in the military that can perform like I do, that look like I do. I mean, it's quite common. I live in a building full of my peers, and most of them are slightly overweight. They've got a relatively high body fat percentage relative to their weight. You see them in the gym, and whenever they do squat, they squat 95 pounds or 115 pounds or something like that. Most of them can run a little bit, but you start looking at your peer group, and yeah, I've had like a couple of orthopedic surgeries, but the vast majority of people that we treat post orthopedic surgery are not people that got hurt training. We treat most of our post-op patients are people that get injured course of life, right? That these are people that have knee replacements that have never trained a day in their life. So squats didn't destroy their knees. So what destroyed their knees? Or we have people with rotator cuff tears that get it repaired, but yet they've never been in the gym a day in their life. But whenever it comes to training, everybody wants to find their exit ramp, or they want to, it's confirmation bias.
Yep.
You think that weights are dangerous, you're going to try it anyways, but then you have this ill effect from it. And now it's like, yeah, I knew it. I knew that this was bad for me. I knew that these were bad for my back.
You know what's cool about our gyms, Will? We have a lot of people that come in like that with a bad attitude, thinking they're going to hate it. And actually the Berkowitzes were the same way. You should watch that video if you haven't, of their interview that Paul Horn did. And Dave basically said he thought he'd go to train. After a month, he'd be like, well, I gave it a shot, back to the couch. But even a mindset like that was changed by the profound effects that he received from going through this process. So I think you're spot on that a lot of people are looking for the exit ramp. But I think it's cool that starting strength can produce such phenomenal results that it can actually change people's minds in some cases.
I kind of work a little bit as kind of like a consultant for you guys, right? But yeah. I'm not employed by Starting Strength gyms. I have no financial ties to your gyms or anything like that. But I do work with a lot of people from Starting Strength gyms. And I do have to just put a plug in here for this. And this was not scripted or anything like that. So you can feel free to edit this out if you don't think it's appropriate. But one of the things that I've noticed about the Starting Strength gyms is that whenever I have one of my clients that trains at a Starting Strength gym is doing their set, it's exactly the same atmosphere Wichita Falls Athletic Club. Whenever somebody, there's no jackassery going on when somebody is about to do their set of squats. Everybody stops, everybody turns, everybody faces the person who's squatting. Whenever somebody gets done with their squats, they re-rack the bar. People applaud them. People tell them, good job. There's positive reinforcement, but the atmosphere itself is like incredible. That in between sets, nobody's training. You see as somebody's getting their camera set up and all that kind of stuff. Everybody's talking. There's a community, right? So these gyms have like created these little communities. And whenever somebody gets up to squat, nobody else is doing anything. Everybody's letting that person focus on the task at hand. There's not people flexing in the mirror. There's not people, doing, Instagram like selfie things. There's nobody acting like a jackass, doing a TikTok dance on the platform next to them or anything to like distract that individual from what they're doing. And like, it's such a great environment that like, I cannot wait to get back to the US because I just want to drop in at whatever the closest Starting Strength gym is to Pennsylvania whenever I get there, because I thought Wichita Falls Athletic Club was the only place that you were going to get that same type of environment, but you've somehow recreated that across all of these gyms.
Yeah, man,
And
it's pretty special. I have to say, I definitely agree with you, and it's a cool place to be. I actually like uploading my videos to share with you because I like showing you the vibe and the people, and it just all comes down to people. You know, the methodology and all the thinking about the program and the way that's been established is the people that created that, Rip, and then the franchise team and all these other guys, Steph, Nick, and then the people in the gyms are the ones that create that environment. They're the ones that create that atmosphere.
And the other cool thing too is you work with somebody at a starting strength gym for you have some longevity working with that person, and you start seeing the same people stepping away from the rack, or putting their bar in as they're getting the camera set up, and you see the weights are increasing, or that the guy that you saw 3 months ago is now significantly bigger than he was 3 months ago. And
Good,
so
man.
you get to see, kind of as a casual observer of these individuals who I don't know by name, but you start seeing, like, not only do you have this community atmosphere there, but it's full of positive reinforcement. Everybody's like kind of pushing you along to do better, but then you kind of see the results not only in the person that you're working with, but with everybody else. And so then that helps kind of push everybody else along, because even if you don't necessarily see progress in yourself, because that's always the hardest person to see progress in, you see progress with everybody else.
Mm-hmm.
And like, I just have to say, man, like it is a pretty unique culture. And the fact that you're able to recreate that environment that you get at Wichita Falls Athletic Club is just, it's awesome.
And it's a pretty easy barometer in my mind when I visit a gym. It's like, if Rip walks in here, is he going to be happy with it? And every time the answer is yes, because we hire the right people, we bring on the right people to open these things, and they hire the right coaches. And then it's the blue book come to life, right? So I'm glad you like it, because once your Army days are over, I hope there's something enticing here for you, and you can join us, because we need your skill set. As you can see, we're working at the moment. We're not involved financially. There's no official setup. It's just we have people that need your expertise. We pass them to you. Everybody benefits. It's all good. And if we can formalize that when you're out of the military, that would be cool to have an official Starting Strength Gym's PT product, So, hey, one last question for you. And because we can go on for hours. And by the way, if we miss anything you want to talk about, come on again, because people gave me great feedback about our first episode. Got a lot of people messaging me out of the blue just saying that was really informative. So my last question for you is, we opened this podcast talking about the unfortunate situation when it comes to not being able to outsource your healthcare. You have to manage your own healthcare and understand what's happening. Otherwise, if you're trusting strangers or trusting bureaucracies or trusting titles, you're putting yourself at inordinate risk. So the reason for that is all the stuff we talked about, but to summarize it, it essentially is a medical professional has to make money. That's incentive number one. A medical professional has to reduce their liability. That's incentive number two. Both of those things drive behavior, because incentives drive behavior. And then they have to do the ethical, moral, job-aligned purpose for going into this profession thing, which is helping the patient get better. But there are medical providers that say, I'm going to help the patient get better, and that value will help me earn money, and then the liability stuff will work itself out if I'm trying to do the right thing. Those are people like you. Those people are very few and far between. Most other people in my experience are, this is the protocol, this is the standard, I'm not here to question, I'm just here to follow orders. And yes, I have a medical degree, but I'm actually not going to go out on a limb, do my own thinking, and take any risks, because what is the upside for me in doing that? I'd rather just play it safe. So the question for you, Will, is, do you have any advice for people that are listening to this, and they've seen a glimmer of this in their own healthcare before, or they believe what I'm saying, and they believe that the stories I'm talking about with these doctor interactions are true, and they're aware of these risks? What advice do you have for the standard person that needs to manage his healthcare and is not a medical professional and has to deal with the standard medical bureaucracy and all of these competing incentives and competing interests? What is someone to do? How do they get the right standard of care?
So I think one of the important things to understand is like a physician, a physical therapist, any medical provider does not necessarily have authority over you, right? We do not direct or order you to do anything. What we are is we're a consult, we're a consultant to you, right? You come to us, you have an issue, and we are a specialized consultant to you. So what I would tell people is you have to be a conscientious consumer of healthcare. And so whenever if you have like a HMO plan or something like that, and you have a primary care manager, and you have your first appointment with that person, and um, that provider does not share your same values or does not understand your values or is not willing to take your values into consideration, then you're going to have to kind of shop around until you find somebody that does. Now, that's a big difference between doctor shopping. All right. So the term doctor shopping is you have a predetermined end state that you want a prescription for OxyContin, and you keep going to doctors until you get what you wanted. That's not what I'm talking about. What I'm talking about is you find a physician or a primary care manager or a physical therapist or whatever type of healthcare that you're requiring at that time, that shares your value or gives you value or understands your values. So like if you go to a physician and you say, hey, I just want to let you know, like, I regularly strength train. This is what I do. And the individual turns around and says, well, you shouldn't be doing that. That's not the provider for you.
I've had
that's
that
not
experience.
The provider for you.
Yeah.
Yeah. And that's not the provider for you. That's not to say that person is not a good physician or provider or whatever. That's just not the one for you. Mm-hmm. And so a lot of times you can, if you do have a provider, you find a provider, which the linchpin of the American medical system is the primary care manager. If you can find a primary care manager that understands your value set and takes those into consideration whenever it comes time to determine your plan of care and stuff like that, then that individual will probably take that into consideration whenever they're making specialty referrals too. And so you're not set. It's not set in stone who you have to see. It just, a lot of individuals, even though nobody goes into a store anymore and buys a product that they've never bought before without pulling up Amazon and looking at the Amazon reviews. Like we'll look at a sound bar for our TV for 3 weeks, and we'll research sound bars for 3 weeks until we decide to make a purchase of $300. But nobody does the same thing whenever it comes to their physician or their physical therapist. I mean, there's websites out there that have reviews of individuals and they have patient testimonials and stuff like that. Now, granted, on the person's website, they're only going to give you the good testimonials, right? Mm-hmm. So I would say that be a conscientious consumer. So search for somebody that shares your values, that understands your values and doesn't dismiss them. Any provider, for the most part, that dismisses your values and says, well, this is the only way that we're going to do it. That provider, if you're looking for something outside of the norm, that's not the provider for you. That's not the provider for you. And you're probably never going to turn that provider around to where they do that. And some people do that. The other thing that I would say is that you have to be careful of anybody who promises you miraculous results.
Or doesn't talk about the downsides.
Or doesn't talk about the downsides. That's particularly troubling. That was going to be the third thing that I mentioned, but we'll cover it together. Individuals that tells you that you're going to get miraculous results, and this is more directed at individuals like physical therapists, chiropractors, and stuff like that. It's very common for practitioners in the allied health fields to offer a certain type of treatment that they're gonna claim that the results from this are better than anything else, right? Craniosacral manipulation for chiropractors cures everything. Voodoo flossing for physical therapists, or trigger point dry needling, or I don't know, Reiki stuff or healing crystals or whatever, like any of these
Lasers.
other like providers or pseudo providers that claim that their technique is markedly better than anybody else, you always have to look at it as probably being dubious to begin with, right? And then outside of that, people who don't talk about the risks, like if somebody's offering a procedure, but they don't tell you the risks of the procedure, or if they minimize them completely, then I would say that that's a provider that you should probably look to replace with somebody else. And so those are the three things that I would say: that you have to be a conscientious consumer. You have to find the right fit for you. And there are just as many physicians, primary care doctors as there are in the world. There's that many different variations of primary care. A lot of the treatments are the same, but having a provider that takes your value set into play, which we're supposed to do as evidence-based providers, we're supposed to take patient values into, and it doesn't take a terminal professional degree to tell somebody not to do something. It does take advanced education to take somebody who's injured and figure out a way for them to get back to doing what they want to do. It doesn't take a graduate degree to say, well, it hurts whenever you run, so just don't run. That's preposterous. But I mean, in a lot of settings, that's as much as you're going to get. And also taking into account that physicians, everybody likes to think that physicians are rich, that because somebody's a medical doctor, that they're just overloaded with cash. That's not the case. They make a good living, but they spent 10 years getting to the point where they actually make a decent amount of money. And the amount that they pay on overhead, the amount they pay on malpractice insurance, they're doing about the same as somebody with an MBA, maybe. You know, somebody who's making a $320,000 salary as an OBGYN is probably bringing in 120, 140 take home each year. They're not strapped with cash. Pharmaceutical companies are not paying these doctors kickbacks. Now, granted, you have neurosurgeons, orthopedic surgeons, something like that can do significantly better, but primary care doctors are not usually extremely wealthy. So they're not making decisions. They're not necessarily making decisions on what's going to bring them the most money. For them, they spent 4 years undergrad, 4 years medical school, 1 year internship, and a 3-year residency to get where they're at to make a comfortable living. They have to protect their license. And the way that the medical community has gone is evidence-based care has kind of created clinical practice guidelines, and clinical practice guidelines become standard of care. But you may not relook clinical practice guidelines in depth, but every 5, 6, 7, 8 years, something like that. I mean, for something like plantar fasciitis, we still have the clinical practice guidelines were dated like 2016.
And they might be wrong to begin with.
Yeah, I mean, at the time, that was the best
protocols that are wrong. Just flat out.
That was the best available. That was the best available evidence. But I mean, evidence is not always completely up to date, you know. And so, whenever you just go cookie cutter approach, and you just go by the clinical practice guidelines, especially if they're dated, you may not be working with the best available evidence. That was the best available evidence when that clinical practice guideline was created. And so, the last thing I would say with physicians is you have to be careful. You have to be careful, but it's a welcome sign whenever somebody tells you what the evidence suggests.
Suggest is a great word. Suggest. Anytime people know or they're black and white in the medical setting, that is a big red flag.
Yeah. Anybody says that science proves this, like that's a dubious claim. Don't listen to that person. That's the complete antithesis of science.
I like it when they refer to science as an entity, like it's some kind of oracle or something. Science is a process.
It's a method.
Yeah.
It's a method.
Yeah.
It's a method. It's a step-by-step process.
Right.
And science is ever changing, and it has to be ever changing. And the science is never settled. Anybody who ever says the science is settled, they are not practicing science anymore.
They're practicing
dogma.
Right. Exactly.
At any time, even though I use compound barbell lifts in my rehab setting, because my review of the literature and the evidence and my experience as a clinician says that is the best available thing right now. If somebody were to bring me a convincing argument that body blade exercises on a Bosu ball produced superior results to barbell training. And it was highly supported by the literature. I would do that tomorrow. I would change my practice tomorrow.
But you would test it. You wouldn't swallow it whole and throw out all of your own preconceived notions.
And then,
you'd say, hey, this might be worth looking into, right?
The evidence says this is a much better rehab protocol than what I'm doing. And I would bring it into my clinic and I would start layering in patients doing that, testing them against the people that are already on that, the historical data I have with patients and how they progress with that. And yeah, if I'm getting much better results with that and some E-stem and hot pack, then guess what? That gym equipment that I have in my clinic is going to go largely unused because I'm going to modify my clinical practice to go best with what the best available evidence right now says. And so having a physician that will say, hey, at the time, the best available evidence suggests this is a superior treatment to this. Just as an anecdotal example, that's exactly how my orthopedic surgeon practices. I went in with him, done an MRI on my shoulder. I had known for a long time that my proximal bicep tendon was the pain generator. I knew that I had a slap lesion in my shoulder because every time at the bottom of the bench, as my humerus translates anteriorly, there was instability there. I would lose stability at the bottom of the bench. The biceps tendon was constantly getting irritated and painful, and it was limiting my workout. Have the MRI. The MRI said that it was exactly what I thought it was. So I go in and I meet with my orthopedic surgeon, and he says, look, man, we can do one of two things. We can do a tenotomy or we can do a tenodesis. Right now, the evidence would suggest that the outcomes are exactly the same, exactly the same. The strength is usually not radically different between the two. They're basically the same. The only difference is that whenever somebody does a tenotomy, that they have persistent cramping and increased fatigability of the bicep in the long term. And so we made the decision to do the tenodesis to give me a chance to maintain that because it might improve my ability to or my resistance to fatigue. And the cramping sucks. Don't get me wrong. The cramping really does suck. But that was the deal. And he provided me with the articles that he was using to make that recommendation. He had them readily available. I looked over them. We made the decision to go with the tenodesis. Then whenever the tenodesis failed, and I basically just became an involuntary tenotomy, then I already had the literature, so I know what the expectations are. And so that was a very refreshing patient care experience to have an orthopedic surgeon who, this guy is a fantastic surgeon. He's a great dude too, but he could have easily just said, look, I'm an orthopedic surgeon. You're a physical therapist. I know more than you. This is what we're going to do. But he didn't do that. And we had a discussion about the type of tenodesis that we were going to do. We decided collectively that we were going to do a tenodesis that was pioneered by an orthopedic surgeon named Matthew Provencher, where we did a double fixation. So instead of just doing the interference screw, we did a cortical button and an interference screw fixation. That's what they do with like highly athletic people. He had never done it before, but in the 2 weeks leading up to the surgery, like he studied relentlessly on how to make sure that he did it and had it done. And my recovery was impressive. And it was just a routine activity of daily living that caused the tenodesis to fail. But that is a perfect example of what a provider should be.
Well, that's a great start to the answer, which is essentially you've got to make sure the person responsible for your overall care is someone who aligns with your values. I think that's a really good start. But I've got a bunch more questions for you on that. So maybe you can come on again because I want to talk to you about building a healthcare team. I want to talk to you about how to fill in the gaps and how to understand what the gaps might be of each provider in that team's skill set. And then for those of you watching, if you want to comment down in the YouTube comments or on the forum with questions that you have for Will, I'll take some notes on those and I'll ask him those during the next conversation. Because
usually in the YouTube comment section, somebody's just they're gonna find one thing that I said that doesn't align with their values, and they'll just they'll just talk shit about that, or they'll talk about that I'm an ugly dude or whatever. The YouTube comment sections, like, just, I almost don't even look at them anymore because there's almost nothing of value.
Well, you know what's great though, man? The comments for the podcast are pretty positive. The comments on the channel lately have been great. But and then there's these knuckleheads that just spew hatred with bad grammar. They're so dumb you can just toy with them, man. So I'll send you a text when that happens, and we'll go back and forth with the guys and have some fun.
Just like, who really has the time to watch? I mean, at this point, this is like an hour and a half or so.
Yeah.
To watch an hour and a half podcast video that probably has nothing to do with anything that they're dealing with or anything like that, to then just go on there and like make comments about how, like, I don't know, that I'm an ugly dude, or that I'm wearing this t-shirt, or like whatever. It's like, who the fuck has time to do that?
Non-productive people. That's who will. The people that go into your office and want to take the easy route. Those are the ones that are spewing hatred and comments on YouTube.
I remember I was given a talk at a starting strength event, and I'm giving this talk, and I had a little bit of a verbal faux pas where I meant to say sex, but I said biological, and I just said gender instead of sex. Obviously, I was talking about sex.
How dare you?
And I just said, but we're talking about the two biological, and remember, like, I'm giving this talk like off memory, right? And I say the two biological genders, and as I said it, I knew I meant sex, but I just didn't go back and correct myself. And then this was like a 2-hour lecture, and you go into the comment section, because I used to go down there because people would ask questions and I would answer and stuff like that. But I go down into the YouTube the comment section, and like there was like comments about like, pointing out that I said gender instead of sex. So obviously I'm completely uneducated. And how did I ever get a physical therapy degree? Man. And then other people were saying, like, obviously this guy doesn't even have whatever, or else he would have just become a doctor. Like, instead of a physical therapist. And it was like, wow, you mean to tell me that like my entire worth as a human being is wrapped up in the fact that I'm not a medical doctor and I'm just a physical therapist instead?
Let's just do this. Like, anyone that criticizes you or has shit to talk, you have a open invitation onto the podcast. We'll talk for an hour. With or without Will, you choose. But I want to show you these people, because I'm getting more familiar with them with this podcast. And most of the people are great. And then you've got these knuckleheads that can't spell, they can't type, they probably can hardly speak, and their thinking is fairly broken. And I feel bad for them. They're in such a bad spot in life that all they can do is just try to look for negative shit to say about strangers on the internet, right? So
yeah, it's wild. Like, yeah. I mean, it's just absolutely, and I think it's hilarious that Rip does what he does whenever he kind of makes light of it.
Comments from
like, I go in there and really, like, it just kind of bothers me, because if I don't even look at the comments anymore, because I just look at it like how much trash there is. Mm-hmm. It's easy. You watch something like this, you don't agree with my approach or whatever, like, just turn it off and move on to something else. Like, this isn't for you. This isn't for everybody. But
it's like the Howard Stern
to
deal.
Take the time.
The people that hated him watched him more than the people that loved him. So, hey, you fuckers that hate us, keep watching. Click like or click dislike. Say something nasty. Yeah. Just feed the algorithm. Thank you. So, Will, let's leave it at that, man, because I will spend my entire Friday night talking to you. That was really, really helpful. And when you're out of the military and we're in the same city, I'm taking you to a nice steak as a thank you, because it's there are a few people that have had a tremendously positive impact on my physical situation, and you're now one of them. So thank you for being my coach and helping me through this process.
Well, it should be passing through the Boise area around the first part of September.
Hell yeah. Good time of year too. If you give me some notice, we can go rafting with one of the members at Starting Strength Boise. He's got a couple rafts for us. Do whatever you want, man. So let me know.
Yeah, I may have to stop in and get a workout in at Starting Strength Boise, just because.
Hell yeah. And before we go, what's that?
The gym culture here is not the same as what you have there.
It's a little different. You're going to love it in person. It's really cool people. I mean,
yeah, I'm looking forward to it.
I can't think of a member at that gym that I don't really enjoy and wouldn't mind hanging out with outside of the gym, Yeah. Dude, so before we wrap up, how do people get in touch with you if they want to pay for your services and get some help with whatever they're dealing with?
As much as I hate it, because I'm an older guy, like Instagram is really the best place to get in contact with me, because the message function on Instagram is probably the most user friendly, and it's easy enough to respond to it quickly. So just go to my Instagram.
Just search Will Morris on Instagram, or do you remember the handle?
It's the handle is Morris DPT SSC.
Okay, Morris DPT SSC, and Morris is with 2 R's, correct?
Yes.
Cool. All right, Will, thanks again, man. I'm happy you're leaving Korea soon.
Always a pleasure, man.
Yep, coming back stateside. Hopefully, going to work with us, and then depending on the response from the knuckleheads in the comments, maybe we'll do round 3 of this too.
Yeah, it's just an interesting dynamic that can only exist on the internet.
Right.
Can only exist on the internet.
What have we
behind the anonymity of the internet and the keyboard? Like people don't act that way in person, and that's kind of a troubling development in society. Is that people are somebody totally different whenever they're behind the relative safety of their keyboard and their and the internet.
In 2022, you can just imagine anything and pretend that's real life. So this is where we are as a species, you know?
Yeah. All right. Well,
leave it on a somewhat depressing note, but when you get back over here, you'll be you'll be in a better mood. The military has a tendency to do that to you. Thank you, Will. I appreciate the time.
All right, man. Yeah, it's always a pleasure, man. It's always a pleasure to talk to you.
Hell yeah. All right. Talk soon. Thanks again.